Good morning to all. Greetings from Lakshmi Memorial College of Nursing. Welcome the new morning with smile on your face, love in your heart, and good thoughts in your mind, and you will have a wonderful day. A warm good morning to all. Always set a goal that makes you want to jump out of bed in the morning. Today, we have a goal to nourish and flourish ourselves with the vast knowledge. We, the nurse practitioner in critical care nursing students of Lakshmi Memorial College of Nursing, have organized this international webinar on post-COVID rehabilitation to provide you in-depth knowledge about pulmonary rehabilitation of post-COVID, depression and anxiety in post-COVID, problems, challenges, and role of nurse practitioner during COVID pandemic in India and abroad. Before moving on, let's invoke God's blessing through prayer song. एक तू ही भरोसा, एक तू ही सहारा, इस तेरे जहां में नहीं कोई हमारा। ईश्वर या अल्लाह ये पुकार सुन ले, ईश्वर या अल्लाह हे दाता। ईश्वर या अल्लाह ये पुकार सुन ले, ईश्वर या अल्लाह हे दाता। हमसे न देखा जाए बर्बादियों का समा, उजड़ी हुई बस्ती में ये तड़प रहे इंसान। नन्हे जिस्मों का टुकड़े लिए कड़ी कमान, बारूद की दुई में तू ही बोल जाए कहाँ। एक तू ही भरोसा, एक तू ही सहारा, इस तेरे जहां में नहीं कोई हमारा। ईश्वर या अल्लाह ये पुकार सुन ले, ईश्वर या अल्लाह हे दाता। It's my privilege to welcome the gathering with immense pleasure. It's my great privilege to welcome our beloved principal, Dr. Larissa Martha Sams. A warm welcome to you, ma'am. Power is gained by sharing knowledge. It's my honor to extend a warm word of welcome to Dr. Teresa Lida Mendonça, Vice Principal, who is an eminent personality in the field of education. A warm welcome to you, ma'am. Her personality is just great. She is approachable whenever there is a problem. She is none other than our class coordinator and organizing chairperson of today's webinar. Dr. Diana Lopo, we welcome you, ma'am. Knowledge and practice will increase critical skill in critical care. It's my gratitude to welcome our preceptor, Dr. Sudesh Rao, Chief Intensivist. We welcome you, sir. I extend cordial welcome to all our resource persons of today's webinar, Mrs. Bijula, Dr. Deepthi VH, Ms. Sridevi Balachandran, and Mr. Prasanna Kumara. I welcome you all. I welcome all the HODs, teaching and non-teaching faculties of Lakshmi Memorial College of Nursing. An NBL welcome to you all. I extend a warm welcome to all the delegates. I appreciate your overwhelming enthusiasm. Once again, I welcome each and everyone. Lamp signifies purity, goodness, good luck and power. The presence of light means the non-existence of darkness and evil forces. Now, I request Vice Principal, Dr. Teresa Lida Mendonça and Dr. Diana Lobo to light the lamp and inaugurate the webinar. The achievements of an organization are the results of combined efforts of each individual to bring out the best of an individual. It takes a great wisdom and courage. I would like to welcome Dr. Sudesh Rao to deliver keynote address.
Good morning, everyone. Um at the outset, I'm extremely thankful to the management, Principal Dr. Larissa Martha Sams, and all the faculties who have joined here today for this the same. Now, at the outset, I am also thankful to the organizing team, especially our NPCC students, Mrs. Sukshma Krasta, as well as Mrs. Roshni, for all their efforts, as well as I'm thankful and for me to thankful for the organizing team for giving me an opportunity to deliver the introductory speech today. I'll be just delivering an introductory speech, which will be followed by the eminent speakers today who will be there with us today to deliver various topics in this particular the main the topics which will be detailed to you in the coming lectures. Now, why this particular topic we have thought to do as an important topic, because there are we all have now gone through the first wave, second wave, and the third wave of COVID-19. Now the question arises after this wave whether this COVID-19 pandemic crisis is over. Is it over, or is there a crisis after a crisis? Now we think that this crisis is done, we are all through, but there is something behind which we need to think that the crisis is not over. We have some symptoms. What is that? We all think we are assuming that around the world, that around the world every one of us are assuming that this whatever the pandemic or the crisis which has happened, once a patient is been discharged and he is found to be in a negative state, that means the problem is solved. But is it really resolved? The question arises here. Now, we need to think that what happens to these patients who have been in the hospital for the COVID-19 treatment and having an extended stay, a length of stay in the hospital, especially in critical areas. What happens to them? We are very much, our presence or our services are needed for them as well. So that is the reason we are today here today to exchange our views and ideas and expertise to share the knowledge and then plan what best can be done to this category of the patients. Now, why is this assumption there? Why do we think that the crisis is over? That's just because of our lack of knowledge, lack of information, which finally leads where the patient is affected and the crisis which is coming after this crisis is not well managed. We are here to gain knowledge today. So the coming lectures by the eminent speakers will give you an insight on what to do after this crisis. Now let me tell you something called as what is PICS, or we call it as PICS, or you should also understand it is post intensive care syndrome. We never give much of importance, but then now we should think, because we have come across horrible, stressful, and a very bad pandemic of COVID-19. Now, what is PICS? PICS is the post intensive care syndrome, which generally is seen in patients who are coming out of the critical areas. But here we are just coming out of a pandemic, so you can as well think that what is the impact or the magnitude of this particular crisis. Might be a next public health crisis after this COVID pandemic. It might be a thing, because it is just not been addressed, and what we are seeing is only the tip of the iceberg. How do we recognize this particular PICS, where this syndrome, which are all the most common symptoms? One is the physical strength deficits. Prolonged stay in the hospital will definitely cause a physical strength deficit. What happens to the neurocognitive state? There is definitely a decline in the neurocognitive state. Mental health, obviously, anyone in a critical area, especially in ICU, will definitely develop a mental health. All this together becomes 60% of our on MACICS is very, very important, which we all have to understand and take care of the patients. This PICS is more common in those patients where they have multiple comorbid conditions. Having acute, these comorbid conditions like diabetes, hypertension, coronary artery diseases, various comorbid conditions will have a direct effect on these patients who develop an acute respiratory distress injuries, where in COVID or any other cause where these injuries can cause a further uh, chance or a higher risk of developing PICS. And all of you know that in COVID-19 ICU survivors, they have gone through all these things. So they are also a highly important category of patients where they can develop PICS. Prolonged length of stay is one factor which causes muscle weakness and which directly affects the quality of the life. The patient might have come out of the ICU, patient might have come out of the hospital, but definitely the coming days is not going to be very easy, because they would have already developed some muscle weakness, which can directly affect or indirectly affect their quality of life. Not only that, this can also affect their occupational changes. Having a muscle weakness will directly affect their performance in their job and other things. You won't believe 33% of the individuals after discharge from ICU will be unable to drive as well. You know that how much we are dependent on and transport, where we need to drive and reach other places where we are working. When you have such limitation to reach, or when you have limitation to transport, what happens? It definitely affects your mobility and even to deliver your social responsibilities. As I said, all these things we don't think, because we think that once the COVID-19 crisis is over, the crisis is done. But my friends, no, there is a long journey. So How can we do it now? Now, how do we solve this problem? Only solution is what our organizers have done today. They have done an excellent job in selecting this topic because this is the only way to develop a system or develop a program where we all can learn the skills of how to take care of these patients. Now, let me tell you, this is the only solution where we can do it by developing an integrated rehabilitation. It cannot be one specialty. It is an integrated rehabilitation. So the word integrated means you can understand that we need to have different specialities and joining hands together to deliver the healthcare. Rehabilitation by how do we do it? By mobilizing our rehab team to the front line. The rehab team has to come front and they have to take care of this patient. You might ask me who are all there in the team. Not only doctors. We need NPCs, that is the nurse practitioners in critical care. The emerging specialty now, here we have our students here in NPCC who are going to be the future. So they have to be in the front line. So not only the NPCCs, we need respiratory therapists, we need physiotherapists, we need occupational therapists, and we need psychologists, and then psychiatrists, nutritionists, rehab physicians. Now you can think how big is that rehab team which has to come to the front line. So each one of us can exchange our skills, exchange our knowledge by developing a program plan or developing a system of taking care of these PICS patients. How do we do it? That is what you have done today. That is conducting national conferences, interaction, and exchange of knowledge. We know that this tele-rehabilitation is probably one of a very good way to deliver this standard of care even in remote places. So virtual rehabilitations or tele-rehabilitations can be done to reach the population who are suffering this PICS after the post-COVID-19 pandemic. So I really congratulate the faculties from Lakshmi Memorial Education Trust, the nursing college, the management, the principal, all the senior faculties, teachers, and our NPCC students for putting their real efforts for a good cause. Let all your efforts be fruitful by exchanging your knowledge. Today we are having all the speakers, so listen to them, ask your doubts, set a plan, and then make a good your protocols and policies and all the various modalities of treatments to integrate and then deliver the best healthcare to this category of the patient. Awareness to families are also very important because they are the one who will be recognizing it in their houses or outside the hospitals. Before it goes into a severe form, it has to be observed with a very good skillful observation. So even public awareness is also very important in this. So when we look back in all this, whatever I have spoken now, we might have not really thought of it because we are worried only about the crisis. Now today you have done a beautiful program, and I congratulate and wish all the team members to have a beautiful day today with a lot of knowledge, and let it be an eye opener for all of us so that this particular care of the patient, that is the rehabilitation, pulmonary rehabilitation, as well as all the the team involved in this rehabilitation should join their hands together and give their best of the care to this category of the patient. Thank you one and all for giving me an opportunity. I have hopefully I have done justice to the introduction talk, and I wish all the students also for their interest in registering this particular event. Please listen to the eminent speakers, gain knowledge, because you are the future, and rehab is an upcoming field, and definitely it is the need of an hour. Thank you, one and all. Good day.
Thank you, sir, for highlighting the importance of today's webinar. Think big, think fast, and think ahead. This is the way we are always guided towards every goal. It's my overwhelming happiness to welcome our beloved principal, Dr. Larissa Mata Sams, to deliver the presidential address.
Good morning, all. It's indeed a pleasure and privilege that our first batch of nurse practitioner in critical care students have this opportunity to organize this international webinar regarding the post-COVID care. It is indeed an achievement that the first batch under the University of Rajiv Gandhi University of Health Sciences, that they are going to complete their nurse practitioner in critical care course, and an opportunity they have utilized to organize this international webinar. So personally, as well as on part of the, as a coordinator of the program they have initiated, I really express my heartfelt congratulations and gratitude to the both of the students, Mrs. Sukshma, and at the same time, I also appreciate the effort that is taken in organizing this international webinar. At the same time, the post-COVID care, the immediate need of the population across the world is a very imminent and important aspect that every nurse needs to focus on. The role of the nurse practitioner is well acknowledged in all the spheres across the world. And we in India, in the infancy stage of this nurse practitioner program, and whoever have completed this course have really played indeed an important role in the COVID care as well as post-COVID care. And the topic that is chosen and the resource person that are chosen are well appreciated, and their insight into these aspects will be well appreciated by all the delegates who are taking part in this today's program. I wish the organizers, the students, the resource persons, as well as delegates a heartfelt gratitude for being part of this webinar. Once again, all the best and congratulations. Thank you.
Thank you, ma'am. Now, let us begin the first session of the day. I request all the delegates to mute yourself. Any queries, kindly type in the chat box. All the queries will be answered at the end of session. I'm happy to introduce the first speaker of the day, Mrs. Bijula. Mrs. Bijula graduated from Sri Jayadeva Institute of Cardiovascular Science and Research Center, Bangalore. She has completed American Association and Cardiovascular Pulmonary Rehabilitation Program under AARC. She has worked as a respiratory therapist in Narayana Hridayalaya, Bangalore. She has also worked as a lecturer in AG Institute of Medical Science and Research Center, Bangalore. At present, she is working in Pulmonary Rehabilitation Center at BMJH in Bangalore. I welcome you, ma'am, and request you to take over the session.
Thank you. Can you see the slides right now? Are you able to see the slides right now?
Yes, ma'am.
Yes, ma'am. Hope you are able to see the slides in full screen itself, isn't it? Can you see the slides? Any one of you please let me know if whether the slides are shared or not.
Not able to see.
Not able to see.
Now can, ma'am.
You can see the slides, right?
Yes, ma'am. Yes, ma'am.
Okay. So thank you for the warm introduction. And while discussing about the pulmonary rehabilitation, most of them will be having a doubt. So many questions because in our country, pulmonary rehabilitation is not in full-fledged form. It is not there. So most commonly asked questions, I have few doubts. So most of the nurses and respiratory care practitioners, everybody is having doubt on these few couple of questions. So in this another half an hour, I would like to answer these questions. Whether I'm clear to the audience, I just want to know. Because my voice is clear to the delegates, please let me know.
Yes.
Yes, ma'am. Yes, ma'am.
And go for full screen.
Ma'am, go for full screen.
Okay. Now it's in the full screen.
Yeah,
right?
yes, ma'am. Yes, fine.
Okay.
Perfect.
So in next 30 minutes, we'll be discussing about another 7 questions. So mainly, most commonly asked question is, what is pulmonary rehabilitation? So while talking about pulmonary rehabilitation, traditional method only will go. Start with the definition. So it's not only an exercise training. Here we are going to assess the patient. Then along with that, exercise training is included. Patient education is there. Along with that, behavior change is there. So overall, we are going to improve the physical and psychological condition of the patients with respiratory diseases. So as we have discussed, it is not only an exercise training. In the pulmonary rehabilitation components, first we have to educate the patients. Educate in the sense from the basics, where the patient is, what are the conditions, what are the problems he is facing. So what are the improvements, how they can manage the disease. So we have to start from there. Then we will be discussing about the exercise training, breathing exercises, and how we are going to assess the outcome in pulmonary rehabilitation, and the nutritional advice also. Along with the nutritional and psychological support also, we are supposed to give in pulmonary rehabilitation. So as Sudesh Rao sir said, we are having so many patients in rehab, not only COVID patients. Before the pandemic were there, that time itself, so pulmonary rehab was running. So who all will be getting the benefits of rehab? Mainly COPD patients, interstitial lung diseases, post-COVID lung fibrosis patient, asthma, bronchiectasis, cystic fibrosis, and pre and post-surgery patients, post-lung surgery patients also will be getting the benefits of pulmonary rehabilitation. So we are ready to start with the rehab. So after sending a patient to rehab, what are the goals? Once a patient coming to the rehab, we will ask the patient. So I'm happy to tell that I'm working in one of the most popular rehab center in India. In India, there are only full-fledged 2 rehabilitation center. One is in Mumbai and another one is in Bangalore. So once when a patient comes to the rehab, we'll ask the patient why you have come to the rehab and what are the goals you want to achieve after completing the rehab. So mainly we can tell them that we will be able to control and reduce the symptoms. That is the most of the patients, they will come to the rehab and they will tell, I'm having breathlessness, I just want to bring it down. So we are going to control and reduce the symptoms of breathlessness and improve the activity tolerance. Activity tolerance means patient will be on 24 hours oxygen at home. So they will tell like, I just want to go to the washroom without the support of oxygen. So after joining to the rehab, we can see an improvement in their activity tolerance, promote the self-reliance and independence, decrease the number of hospitalization. That is most important, especially in case of COPD and all. We are seeing so many acute exacerbations and increased number of hospitalization. So once when they are coming to the rehab, we can see the decrease in number of hospitalization. Overall, we can tell that after joining to the rehab, definitely there will be an improvement in quality of the life. Hope my voice is clear and video is being shared, slides are being shared properly, isn't it?
Yes, ma'am. It's clear, ma'am.
Okay, thank you. So we all are going through a pandemic phase. So after COVID, what is happening to the lungs? Mainly, we can see reduction in the diffusion DLCO, diffusing lung capacity. So mainly we are seeing DLCO reduction in the DLCO as well as the pulmonary interstitial damage. So which is leading to pulmonary fibrosis. And we can see CT scan. In the CT scan, mainly we are seeing parenchymal bands and interlobar septal thickening we will be able to see in CT scan, which is a clear-cut image. Honeycombing also will be able to see in CT scan. So, which indicates that patient is going to have pulmonary fibrosis. An article from Indian Journal of Tuberculosis says that 1/3 of recovered COVID patients, it's very high number, 1/3 of recovered COVID patients are showing fibrotic changes in their CT scan. So we have to be very careful. The patients will be in ICU for a few days. Then after the ICU, they'll be in ward. Then they will be discharged. But later on, what is happening? Who is there to follow up? So there comes the role of a respiratory therapist and the nurses, those who are seeing the patients frequently. So if they are having any fibrotic changes, they'll not be knowing about that, but they will complain like, I'm having breathlessness, I'm not able to walk, I'm not able to talk continuously, I'm not able to climb the steps. So that times that is an indication patient is having dyspnea. And if the CT scan shows that if there is any fibrotic changes, we have to go for pulmonary rehabilitation. And what is the pathophysiology of lungs after COVID? Mainly inflammatory exudative phase will be there. That is leading to fibrotic changes. So I'm not going to detail about pathophysiology, but in this another few minutes, I would like to discuss more of practical approaches of the rehab. So all patients like COPD or COVID patients, they are not being referred to the rehab. Then who all will get reference for the rehab? Mainly patients with dyspnea at rest. Patients are having breathlessness even during rest or with exertion. Most of the patients will be on oxygen for 24 hours. Even with the support of oxygen, patient is having dyspnea. That kind of patients you will get in rehab. And another patient is decreased activity tolerance. Patient was fine before COVID. After that, I am not able to do my day-to-day activities. Most of the patients after COVID infection, they complain that initially I was doing so many activities I was doing, but after that I am not able to do any of the activities because of the breathlessness. So such patients will get reference to the rehab. And failure to stabilize or improve medical management, and along with that decreased quality of life most of the patients, even youngsters, those who are below 50 also, even they were having fibrotic changes and their quality of life is being reduced. So that patients and increased hospitalized the patient, anxiety, panic attack patients also will get reference to the rehab. So mainly we have to think, if the patient is having decreased activity, patient is having breathlessness, or if he's complaining of frequent breathlessness or dyspnea, all those patients will come to the rehab. How long they have to do the rehab? Next question, most commonly asked question, if they come to the rehab, most of them they'll ask, how long I have to continue the rehab? Mainly even for COPD and ILD, including COVID patients, they have to come at least 6 to 12 weeks of rehab. 6 to 12 weeks means every day they are not going to come to the rehab. Weekly, twice or thrice. Otherwise, if they are coming regularly to the rehab, then there is a chance of muscle fatigue. Immediately after the COVID infection, we will not be able to make them exercise. So how rehab is organized, that we'll discuss in upcoming slides. But just to brief you, patients who are coming to the rehab, they will not come to the rehab daily. They will come weekly, twice or thrice, but they have to come at least 6 to 12 weeks. If the patient is in the rehab, it is not only the machine training. So basic home exercise also will be discussing. So that exercises they have to do every day at home. If the exercise training is maintained at home, definitely we can see an improvement in their quality of life. But we can't include every patient to the rehab. There are some exclusion criteria. Unstable cardiac disease, especially in case of acute MI and all, will not be able to recruit the patient to the rehab. Severe orthopedic problems like fracture, bone fracture and all, we will not be able to include them. And along with that, lack of motivation means patient will be coming hardly twice or thrice to the rehab. But after remaining days, they will stay at home. That time they have to do the exercise regularly. But most of the time what happens is most of them will be having lack of motivation. So pulmonary rehabilitation means it is not only the responsibility of a single member, it's a teamwork. Pulmonologist, intensivist, physiotherapist, respiratory therapist, nurses, psychologist, nutritionist, they all has to work together, then only we can see the results. So most of the patients, those who come to the rehab, they will be having comorbidities and they will be having lot of lack of motivation, and severe psychiatric illness like anxiety, panic attacks, depression, all those things we face in rehab. So that in today's topic itself, there is some psychological approaches to the rehab. So hopefully we will discuss in that time. Then how pulmonary rehabilitation is organized. Especially, first we have to get reference from consultants. Unfortunately, in our country, there is less number of pulmonary rehabilitation center, but from various part of the country, we used to get reference for the pulmo rehab. First, they have to practical approaches is very less in practical awareness is very less about pulmonary rehabilitation. Even physicians are hesitating to send the patient to the rehab because only few centers are having proper pulmonary rehabilitation. So first I request all the physicians and consultants to refer the patients to pulmonary rehabilitation. Even virtual rehabilitation also can be done. Once a patient coming to the any center, anywhere from the place, first we have to evaluate the patient. We will not be knowing anything about the patient. First we have to evaluate the patient. We have to do the assessment. It's like complete history we have to take. All the assessment, the PFT, chest x-ray, echo, all the reports we will be evaluating, and we have to do a pre-rehab walk test. Walk test is, it's a field walk test. How to do the walk test? It is not, walk test is not common, but it is, unfortunately, most of them, they are not following proper protocols to do the 6-minute walk test. So in upcoming slide, we are going to discuss about walk test also. So first we have to get the reference from the consultants. Then we have to do the assessment to the patient. Then we have to do the 6-minute walk test. Mainly we are doing 6-minute walk test. There are some other walk tests also. So patient is, we have evaluated the patient, whether the patient is ready to join the rehab or whether is there any exclusion criteria. Everything we have to evaluate. We have to discuss with the consultants and respiratory physicians. Then we are going to start the rehab. So in the rehab, first we have, once when the patients come to the rehab, we are not going to start with all the machine exercise. First we have to explain the home-based exercise training. Then after that also we'll be discussing in upcoming slides. Then comes the machine exercise. So first when the patient comes, we have done the assessment, walk test, home exercise, machine exercise. Then we have to assess the outcome. When the patient came to the rehab, what was the condition? That we are going to assess through the walk test. After the walk test, after the 6 to 12 weeks of rehab, we are going to again do the walk test. So to compare pre and post rehab improvement in patients. So once when the patient, we have got the reference from the consultants, patient has come to the rehab. How to start the rehab? From where we have to start the rehab? So first, most important is we have to counsel the patient. We have to counsel the patient means most of the patients, unfortunately, those who are coming to the rehab, they will be on any inhaler device since so many years. I'm very sorry to tell that most of them, they don't know how to use proper inhalers. Even patients were, excuse me, even patients were using MDA to the nose also. So we should discuss to the patient, we have to counsel the patient how to use the proper, in this slide, you will be able to see some, you will be able to see some aerosol delivery equipments. So we have to educate the patient. So whatever medicines the physician has prescribed, that has to go to the patient properly. So first, in pulmonary rehabilitation, initially we are going to discuss about the aerosol therapy devices to the patient. And if the patient is on oxygen, home oxygen, that time we have to instruct how to use the oxygen device properly. How, if it is a concentrator, how to use. We have to keep that oxygen concentrator in a properly ventilated area. Recently, I had a patient. The patient was a general physician wife. The patient was not knowing that where to keep the oxygen concentrator. The patient was keeping oxygen concentrator in a fully sealed room, and she's telling, I'm not getting the oxygen and my oxygen saturation is not going more than 90. So most of the most of them, they are not aware about the oxygen concentrator and how to use the oxygen properly, how to sterilize the humidifier. All those basic things you have to explain clearly to the patient, especially nurses. While most of the patients, if the patient is on hospital, most of the time they will be seeing a nurse. So that time you will have a lot of interaction with the patients. I know in the ICU 1:1 ratio will be there, but in the wards I know there is a 1:2 ratio is not possible. But still, if you get time, you have to educate the patient how to use the MDI. If even if they are not coming back to the hospital also, if they are not coming to the rehab also, this is a small request and small advice we can give to the patient: how to use MDI, how to sterilize the oxygen humidifier at home. And if they are using BiPAP at home, how to use the BiPAP, how to put it properly. These are the very minute things which we are not explaining clearly, but which later on, if the patient is not using BiPAP and oxygen properly, later on the patient will go for respiratory acidosis and further complications. So we'll start from the basics like aerosol therapy, oxygen therapy, and humidity therapy. So if the patient is using portable concentrator, how long it will last, all those things we have to explain clearly to the patient. Then we have got the reference from the physician. We have done the assessment. We have explained the patient. We have counseled the patient. Now comes 6-minute walk test. So a 6-minute walk test, mainly we are following ATS guidelines, American Thoracic Society guidelines we are following. In that, most of the hospitals where even I have worked also, there we were not following proper protocols. So I will just explain about 6-minute walk test. For that, we have to keep 2 traffic cones. In this, you are able to see 2 traffic cones in 15 meters distance. So the distance here mentioned is 30, but we have to keep in 15 meters distance from from one traffic cone to the other traffic cone. We have to ask the patient to walk as fast as possible. Why I am explaining this in this presentation is, most of the hospitals, they are not following proper protocols. Even respiratory therapists are not aware how to do the 6-minute walk test. So I'm just taking a couple of minutes to explain this. Even for not only for rehab, for some other purpose also we can use 6-minute walk test. So from one cone to the other cone, we are asking the patients to walk as fast as possible. In between, if the patient is feeling any tiredness, breathlessness, anything, we can ask the patient to stop. But make sure that you are not stopping the timer. We have to keep the timer on and ask the patient to walk for continuously 6 minutes. In between, if the patient is not stopping, please don't stop the timer. That is the common error everybody follows in hospitals. So every minute we will be recording the saturation, heart rate, and box score, everything. So at last we will be measuring the distance, and based on that, physician will have some other treatment plan. So make sure that we are doing 6-minute walk test properly. And if you have time, just go through the ATS guidelines, which is available in the Google. So we have got the reference, counseling over, assessment done, 6-minute walk test to the rehab is also over. Next patient is coming to the rehab. In rehab, we are starting with the basic home exercises. Basic exercise will start with most of the patients, they are having desaturation. So if the patient is desaturating, how to manage? If their carbon dioxide levels are high, desaturation is there. So most helpful, the most beautiful exercise is pursed lip breathing. Mainly we are using in COPD patient. Even for COVID patients also, there are some articles showing that there is an improvement in oxygenation level if the patient is doing pursed lip breathing properly. So how to do the pursed lip breathing? There are so many exercises. Just 2 exercises I would like to share in this video, in this presentation. Pursed lip breathing, ask the patient to take a deep breath. We have to ask the patient to take a deep breath through the nose and hold it for 2 to 3 seconds. Then breathe out through the lips, through the mouth. That time, ask the patient to hold the lips in whistling posture. Most of the centers, most of the respiratory therapists, nurses, they are not explaining clearly. If the patient is not holding the lips in whistling posture, then it is of no use. Pursed lip breathing is equivalent to a PEEP on ventilator. The positive end expiratory pressure on ventilator is equivalent to pursed lip breathing. Ask the patient to take a deep breath and hold it for 2 to 3 seconds. Then breathe out very slowly, gently through the mouth. This exercise I'm asking most of you to explain to the patient so that their oxygenation will come to normal. Within few seconds, you just keep the probe on patient's hand. If the patient is doing properly, then within few minutes you can see the results. And make sure that inhalation exhalation ratio is 1:2. If the patient is inhaling for 4 seconds, ask them to breathe out gently through the mouth. Like this, ask the patient to breathe out slowly, gently through the mouth. If the patient is trying hard to breathe out, then exercise induced bronchospasm will be there. So they will come after doing your exercise, I started coughing. That is not because of the pursed lip breathing, that is because they were trying hard to breathe out. So make sure that you are not giving wrong information to the patient. Make sure that patient is exhaling very slowly through the mouth for gently, at least 1:2 ratio they are following. And next is diaphragmatic breathing. This pursed lip breathing, how long they can do? Many times, like we said, like patients will be having breathlessness, especially while walking, while climbing the steps, while talking continuously. That time, you ask the patient to do pursed lip breathing. It is very easy. Inhale through nose, hold it, breathe out slowly through the mouth, 1:2 ratio. Hope you are clear about pursed lip breathing. I feel like it's a magic exercise for most of the patient. Those who are coming to the rehab without oxygen, they will be gasping, and if they do pursed lip breathing for few minutes, we can see improvement in them. So yourself, you just go to the patient side and practice. Nurses, please do that. It is not nurses, most of them I have seen, they will be busy with their record, filling the files, all those things. Along with that, try to spend time to interact with the patients also. So if the patient is getting benefits, yourself you will be satisfied, and you can also feel the happiness of the patient. And the diaphragmatic breathing. In the diaphragmatic breathing, we are asking the patient to keep one hand in their diaphragm. While inhaling, the diaphragm has to bulge out. Here in this picture, you can see in any posture, even while sitting also, they can practice diaphragmatic breathing. Ask the patient to inhale through the nose. While inhaling, the diaphragm, the abdomen has to bulge out. While breathing out, the diaphragm has to go back. So these are the main breathing exercise which we explain to the patient. There are so many other exercises like segmental breathing, hands jogging, chest flight, which I am not going into detail. So at least practice pursed breathing. Inhale through the nose, exhale through the mouth, 1:2 ratio. Please do that. Then the patient is coming to you, there is no oxygen support, patient is gasping. So how to help the patient? In practical approach, if the patient is there, not only in the hospital setup, if the patient is outside, so that time how you are going to help the patient. In these slides you can see 3 postures. One is ask the patient to lean. If there is no chair, you can ask the patient to lean against the wall. Another one, you can ask the patient to lean forward and take the hand support with on your thighs. These 3 images will help you to explain relaxation posture. If the patient is desaturating, and ask the patient to stay in this posture for a few minutes, then you will be able to, the patient will be able to recover fast. And what are the equipment we are using in rehab? This is not only in the rehab, even at home also they can use incentive spirometry, lung boost, a cappella, shaker deluxe, band exercise, TheraBand. Mainly in pulmonary rehabilitation, we are trying to improve patient muscle strength and muscle endurance. To strengthen the respiratory muscles, we are asking the patients to use incentive spirometry, lung boost, and PEP devices. PEP devices, we can bring out the sputum also. And for the flexibility and stretching, we are asking the patients to use band and TheraBand. Incentive spirometry, lung boost, PEP devices like a cappella, shaker deluxe, and this is a stick exercise, band exercise, mainly to improve the flexibility and stretching of the body. So this is the pulmonary rehabilitation center where I work. These are the equipments we are using in our rehab. The first machine, this is called this one. This machine is called upper body ergometer, and the other one is total body ergometer. This one is also total body ergometer, and the treadmill. So in rehabilitation, mainly we are focusing endurance training and patient muscle respiratory muscle strength and endurance training. So when a patient come to the rehab, we have to make an individualized treatment plan to the patient. The machines which we are using will be same, but we have to make individualized treatment plan. Patient goals will be different, so based on their goal we have to make a individualized treatment plan based on their symptoms, based on their activity tolerance, and based on their psychological concerns, knowledge, and after seeing their comorbidities, we have to make individualized treatment plan. Then we have to continue. So in the respiratory, mainly once when a patient come to the rehab, first we have done the assessment, 6-minute walk test is also over. Then we are going to explain the home exercise like pursed breathing, diaphragmatic breathing, all those exercises we are going to explain to the patient. Then we are asking the patient to come weekly, thrice or twice to the patient. So based on the 6-minute walk test, we have to do some calculation. In these machines, we said we are going to make some individualized treatment plan to the patient. What is individualized treatment plans? I will give you a couple of examples. In that, one patient will be coming to the patient. If the patient is after COVID, patient was 50-year-old man. he was fine, but he had difficulty while walking. He had breathing difficulty while walking. So in the 6-minute walk test, the patient's box score was 5. Box score was 5 before coming to the rehab. After completing the 6-minute walk test, he walked only for 150 meters. During the 6-minute walk test, the patient walked for 150 meters. Then after that, the patient has come to the rehab. He was not using inhaler properly, given proper instructions to the patient. He has come weekly thrice to the rehab, and he was doing all the muscle strength and endurance training. What is strength and endurance? Strength means if the muscles are strong enough, if while giving force, if your muscles are strong enough, you will be able to lift a heavy weight. If your muscles are having good endurance, you will be able to do so many contractions with that muscle group. So to do some activities repeatedly, you should have to walk, you should have muscle strength and endurance. So in these machines, we can set individualized treatment plan. So that patient, before box score was 5, after completing 6 weeks of rehab, patient was walked much distance better than the pre 6-minute walk test. So like that, we can see improvement in patients. This upper body bike and lower body bike mainly focusing larger muscle groups of our body. So each session, how long the rehab will be there, it depends upon the patients. Some patient will be able to finish all the exercise within 1 hour. Most of the time what happens is, in these machines we can give interval training also. First, based on individualized treatment plan, we are planning like in this upper body bike, our target is today the patient is going to exercise for 5 minutes. But in between, if the patient is having severe breathlessness, we will not ask the patient to continue with the exercise. We will give them break. Here you can see oxygen ports. With the support of oxygen also, they can exercise in rehab. So once when the patient comes, after seeing the patient, we have to decide. If the patient is not able to continuously do for 5 minutes, after 2 minutes, you give them a break. Then after 1 minute, again, we can start the rehab. So interval training also will give the benefits of continuous exercise training. So these are the main post-COVID lung fibrosis patient, how we are managing them. Mainly, we are going to use the same machines only. We are focusing the strength and endurance training of the patient with the use of supplemental oxygen. Post-COVID patient, if the patient is having fibrotic changes in their lung, during the exercise, very fast they are desaturating. So that time we have to be careful. During the 6 minute, if the patient is desaturating less than 80, definitely we have to start the exercise training with the support of oxygen. Then mainly we have to explain about energy conservation techniques. Energy conservation means how to plan their day. They should have proper energy conservation techniques. Means the patient has to plan their day. What are the things I have to do today? According to that, we have to split their energy levels. Means morning, what time they have, from what time they are starting their day. So if the patient want to take the bath, immediately he should not rush to the bathroom. So first you have ask the patient to gather the items, then do the pursed breathing, then walk half of the way, then take the rest, then go to the washroom. There you practice pursed breathing. Definitely it will take time, but it will give much improvement. After in the bathroom, they will not have respiratory failure and cardiac arrest. So we have to give them clear idea. If the oxygen desaturate below this, some patients will tell, my oxygen is used to be 60s, but I can manage. But we don't know what time they are going to collapse. So we have to counsel the patient and we have to explain the risk also. Then based on that, we have to plan their day. After 16 or 18 sessions, we have to repeat the 6-minute walk test, discuss with the consultants. Then we have to explain them home exercises. After completing the rehab, if they are ready to continue the rehab, then it is well, their muscle strength will be even more better. But even after completing 18 sessions, they have to continue. Like we have shown some device like the Ra band, elastic band, all that will definitely help them. So we have to give them a confidence, and you have to tell them you are strong enough to go through it and you are not alone. That is most important. We should give them confidence, and they should feel that they are confident enough to go through it, and we are there to support them. So this is a brief discussion about pulmonary rehabilitation. Here comes the end of my slide. If you have any queries, please let me know. Thank you for listening. I'm done with my presentation. Is there any queries to ask? Hope I am on time. I wanted to finish by 12 o'clock. Hope I didn't exceed your time.
Participant, please note, it's the time for discussion. Please raise the questions. You can unmute yourself. Any queries? Kindly type in the chat box.
Whether everybody knows everything about rehab or they all just participating just for the certificate. No queries. It's a huge
Thank you,
topic.
ma'am.
It will take time
It
to.
was wonderful to.
Yeah.
Ma'am, please
So,
continue.
yeah, what I wanted to tell is it's a huge topic, and practically nowhere it is practicing. Definitely it will take some time for them to understand. From the basics, they have to at least, if you can organize some workshop on pulmonary rehab, if they see practically more than explaining in one day, if you hands-on session, if you give to the participants, then it will be more helpful, more than explaining in slides.
Sure, ma'am. In future, we will do it, ma'am.
Yeah, definitely.
Thank you, ma'am. It was
Thank you
wonderful to hear you.
for
You
giving
have
me an
explained
opportunity
in
to
depth
discuss.
regarding the pulmonary rehabilitation on post-COVID. Thank you, ma'am.
Thank you.
You had you.
We will move to next session. I call upon Mrs. Sushma to introduce second speaker.
Dr. Deepthi VH, consultant psychiatrist, currently working as an assistant professor in the Department of Psychiatry, AJ Institution of Medical Science and Research Center. She has completed MBBS and MD Psychiatry from KSAGDE Medical Academy, Mangalore. She have academic and clinical experience in the field of psychiatry since 8 years. She has conducted and organized several awareness programs through the mass media and the radio programs covering various mental health concerns. She has conducted research work mainly focusing on mental health and presented scientific papers and posters in various national and international conferences, and she won award for the best poster in the state level conference served as Honorary Secretary of Mangalore Psychiatry Society for the year 2018 to 2019. I welcome you, ma'am. Kindly take over the session, ma'am.
Thank you so much. Am I audible?
Yes, ma'am.
Okay. Hello, everybody. So today I'll be briefing upon the topic post-COVID depression and anxiety disorder. So we already had a good session by Madam about rehabilitation, pulmonary rehabilitation. Now we will see what about the mental health after COVID. So the simple definition of health, according to the World Health Organization, itself states that it is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So mental health is very important for the health status. Okay. And nowadays, the mental disorders are among the common leading causes of the global health-related burden. The GBD, that is the Global Burden of Diseases, Injuries and Risk Factors study 2019 has shown that the two most disabling mental disorders being the depressive disorder and the anxiety disorder, both being ranked among the top 25 leading causes of burden worldwide in 2019. With the emergence of the COVID-19 pandemic in 2020, it has caused a significant and variable psychological impact, both physically and emotionally. We all know that. We all have faced. So what it has caused, this graph and study shows that how the increase in the depression and anxiety disorders, along with the psychosis, has been seen post-COVID, that is after the lockdown. The survey has shown there is a drastic increase both in the moderate and severe cases of depression and anxiety disorder. See, another study has shown the development of new mental health illnesses, which is diagnosed within 90 days of the diagnosis of COVID. And especially the patients who are admitted in the hospital, around 22% have shown anxiety-related issues, and the patients who were admitted in the ICU and recovered, around 38% have shown depression. And the other symptoms which patients have reported includes altered sensorium, insomnia, memory retention is decreased, poor concentration, and critically ill patients have come up with post-traumatic stress disorder and also post-intensive care syndrome, which will be dealt in the next session. So this is one more study which shows that the impact of COVID on people with pre-existing mental health problems. So this is the total population, which is there in the red, and the other one is the pre-existing mental health issues. So the patients were asked about the emotions that they have felt as a result of COVID-19. So it showed that around 67% of the people who were already having mental health issues were anxious, panicked around 23%, and felt like hopeless, that is the low mood around 31%, which is more than that of the total population. So this is a slide which shows the direct impact of COVID-19. It may be a short term or a medium or a long term, and the indirect effects of COVID-19 on the people. So the direct effect, the threat from COVID-19 itself, many of us have faced anxiety. It may not be an anxiety disorder, but maybe an adjustment disorder, but it can precipitate the anxiety and exacerbate the existing illness. The bereavement caused by the COVID-19 can precipitate depression. Not only these, the indirect effects, it's not that only the health related to COVID can have a direct impact on the mental health. It is the surrounding, what exactly is happening in our environment also plays a role in the development of the mental health issues. So that is lockdown and isolation, physical distancing, fear of potential economic impact, adversely affecting the personal relationship. All these things have a total role to play in the occurrence of the mental health issues. Coming to the medium and the long term, that is post-ICU syndrome. Many of the patients who have recovered from the post-ICU have presented with anxiety, depression, and even post-traumatic stress disorder. This is mainly because of multiple factors, that is the illness in itself and sensory deprivation, being in the ICU because of the sensory deprivation, a lot of medications, away from family, and even the threat of the illness. Okay, will we recover or no? What is the next? So all those uncertainties have pushed the patients to develop a certain mental disorders. Next is the bereavement, which can cause prolonged traumatic grief or complicated grief. Along with this, as I already said, there is the other factors, that is the financial factors, job insecurities, income reduction. All these together can push a patient even to have suicidal ideas and thoughts of self-harm. Along with this, there are increased chances of developing substance abuses like increased consumption of alcohol, tobacco, and other substances. This also has a direct impact on the mental health and even the treatment of the COVID-19. So altogether, when we have to say what are the mental health challenges faced by the patients with COVID-19 treated or recovered, or even before acquiring COVID-19, are concerns about one's own health status, concern about health of loved ones, uncertainty about the situation around, adjustment with the new learning environment, and adapting to the new ways of living, that is the use of masks, social distance, hand wash, avoiding crowded area. It is very easy to say that, okay, you have to follow or patient has been recovered. But when you have to actually come to the real practical issues, like after the acquiring COVID infection and recovering, adapting to the environment, that is going to the work or meeting the family, some sort of anxiety and uneasiness will be there. How to cope up with it, we will discuss in the next slides. So along with it, I have already mentioned the response to the social isolation also plays a huge role. The psychological response by each individual will be different to the diagnosis of the COVID, and the public response. So initially we had seen there was a lot of stigma related to COVID-19. That is, if anybody comes out to be positive, people used to avoid meeting them or speaking to them. So people used to feel isolated. At the same time, the illness in itself requires isolation so that it doesn't get transmitted to the others. So people used to feel low, at the same time, no much of psychological support. So what are the range of experience the people have with respect to the thoughts, feelings, and reactions of the illness? That is, the patients might feel stressed, overwhelmed, anxious, worried. You might have seen patients having sadness, being tearful in the ward, concerns about their family member, even the physical complaints like increased heart rate, breathlessness, stomach upset. So which is going in parallel with that of the COVID-19 illness itself. So everybody knows that breathlessness is one of the things which we have to note down in COVID-19. At the same time, anxiety also causes the similar complaints. So it's like a thin layer if the patient is suffering from anxiety or if the patient is actually deteriorating from the COVID-19 illness. So it's a thin layer. But anxiety also can worsen the illness, and there can be an exacerbated illness which can be seen. Next, there is frustration, irritability, anger, restlessness, feeling helpless, difficulty to concentrate, and sleep disturbance, which is seen because sleep is very, very important for the recovery of the patient, for a good mental health and the physical health. So at the same time, the patients may feel disconnected from others, being apprehensive, and trouble relaxing. So what exactly is coping? Now that we have seen so many emotions and thoughts which the patients are experiencing, not everybody would cope up in same fashion. It's very easier to say, okay, you've recovered and you'll be fine, you can get back to work. A lot of people have come out of COVID. Most of us have been contracted with COVID. So it's not the same for every individual because every individual have their own coping mechanism, have their own support system. So being in the mental health professional, when a patient is admitted in the hospital or in the ICU, it becomes very essential and important for the nursing staff, for the medical health professionals, for the staff to know the background of the patient, what support system the patient has, how the patient had coped up before without the illness. Is there anything which is concerning them? Did they have a pre-existing mental health illness? All these things have to be noted down because for the care post-COVID or during the treatment. So, what exactly is this coping? It's the way in which we respond to or manage stress, the uncomfortable emotions, the ways in which we respond to life's demands. It may not be related only to the physical illness or the infection. It may be to anything, any social issues, any psychological issues, or even disease related issues. So, how exactly it is coping? Is it a positive or an adaptive? So it can be an adaptive or it can be an maladaptive. When I say maladaptive, it can be like coping up by the use of substances like alcohol, smoking. You would have seen patients saying that, no, I smoke because I feel relaxed. I smoke or I take alcohol because I get sleep. But these are the temporary mechanisms which the patient might feel better at that time, but it will worsen the condition, both the physical health and the mental health, because a lot of studies and surveys have shown that the substance abuse in itself can exacerbate the existing mental health issues. It can go up to chronic mental health concerns. So these are all the maladaptive ways of coping. So what are the adaptive ways of coping? These are the healthier ways of coping, and that the strategies I'll be dealing in the next few slides. So what happens if a person doesn't cope well? That's when they are at risk of developing the common mental disorders, that is the anxiety and depression. Today we are going to cover what exactly is the depression, what exactly is anxiety. So when a patient comes to you and says that he's feeling low, he's feeling uneasy, lack of interest, can you diagnose a patient directly with depression? So when do you call it as adjustment disorder? When do you call exactly a patient to have a depression? So here is the International Classification of Diseases, ICD-10. According to it, the key symptoms, that is, there should be a persistent sadness or low mood. There should be a loss of interest or pleasure in the activities which were pleasurable earlier. Okay, there is fatigue or low energy. So at least one of these three features, which should be present most of the days or most of the time for at least, what is the duration? It is 2 weeks. Along with this, if any of the symptoms, that is the associated symptoms like disturbed sleep, there might be an early awakening, or in young adults and adolescents, there might be an increased sleep. Okay. Poor concentration, low confidence, there can be a guilt, self-blame, unworthiness. They might say that I'm feeling hopeless, I'm feeling helpless, nobody can help me, and a lot of negative thoughts, and that is called as the pessimistic view about the future. Along with it, patients can come up with suicidal thoughts, that is the death wishes. What's the point in living? Why am I supposed to live? I'm a burden to the family. I think already have got the infection. There is no one who can help me with. I have heard a lot of news. I've heard a lot of complications which has occurred. I'll be debilitated. I can't do anything. These are the negative thoughts which the patients come up with, and we have to be careful about it. We have to be alert about when such symptoms have been mentioned by the patients. So the 10 symptoms then define the degree of depression. So it's like mild, moderate depression, and severe depression according to how severe the symptoms are, what are the symptoms, and how much it is impacting the social and the psychological issues. Coming to anxiety, in brief, I'm just going to tell what exactly is anxiety. I think most of us do face anxiety. We become anxious whenever we have to present or we have something to perform or when there is a threat. So is it, can we diagnose ourselves with anxiety disorder? No. So there is a criteria for when can we diagnose a patient with anxiety disorder. So what exactly is anxiety? It is a normal response to an unusual or stressful event. It is the psychological component or the flight or fight response, the autonomic nervous system, which plays a role. So when is it called as abnormal? When the anxiety is excessive, when it is severe and prolonged, it occurs in the absence of any stressful event. When I said it's not a hard and fast rule that there shouldn't be any stressful event, even in the presence of stressful event also, they can present with anxiety disorders. But the main feature is it impairs the social, physical, or occupational functioning. The person can have raised heart rate, palpitations, breathlessness, choking sensation, tremors. So these are the sudden bouts. It is called as a panic attack, a sudden bout of sweating, gasping for breath, impending doom. They would want to rush to the casualty because they feel breathless, they are not able to breathe in. So these symptoms clustered together, it's called as a panic attack. And when there are number of episodes, the multiple episodes which occurs in a day, it is called as panic disorder. Okay. It is self-remitting because after a while, some patients may say that initially they've had like half an hour episode peaks, and then slowly it keeps coming down. Okay, even without any medications. So here is a case scenario of a patient who had got infected by COVID. After 3 weeks of treatment, the patient said, I was healing from COVID at home, had no fever and just a little cough. But sometimes at night, my breath could go away all of a sudden, making me feel as if I was to die. I knew what it was because I had suffered from panic attacks in the past. I stayed there out on the balcony for hours, trying to put fresh air into my lungs. It was terrible. Panic made me suffer more than the COVID. This is a patient report. At least the patient knew that the patient was suffering with an anxiety or a bout of anxiety. Otherwise, the patients usually come up with worsening of symptoms, saying that no, I'm having a complications. I think I'm not treated well. Still, I have been infected. I'm not able to breathe. Can you please admit me or put me in the ICU? Start with the oxygenation. So there can be a panicky kind of situation which can be created if the patient doesn't acknowledge or has no aware of the illness what the patient is suffering with. So as a medical health professionals, what we are supposed to tell our patients to recognize what's typical and what's not. So I've just put in a few simple, brief methods wherein you can identify and tell your patients. So you can say the patient that stress is normal psychological and physical reactions to the demands of life, and that everyone reacts differently to different situations, and it's normal to feel stress and worry during a crisis. But when you say that if despite the best efforts, despite the care and concern which the medical health professionals give at the time of admission or post-COVID to the patients, if there is a need where they may have mental health concerns such as anxiety and depressions, which I've already covered, if there are certain conditions, then they need to seek help. So these are some of the self-care strategies, which I think once the patient is admitted as a nursing care staff or the medical health professionals can tell them, prepare them how they can slowly adapt themselves. And even it is for the patients who have not got infected but slightly infected, how they cope up with, so that it helps continue a safer life. It's not once you have a depression you need to treat. It is well be prepared before itself. Keep your mental health strong so that if it happens, one can fight and come out of it in a much better and a healthier way. So self-care strategies are good for mental and physical health and can help you out of your. So it's simple, we all know, but I think it's difficult to adapt, and we usually ignore these things. So let us see what exactly it is. focus on the actions that are in our control. So these are the things which we can control. Your patients. So these are the simple things which we can control and to do. So maintain the day-to-day activities and the routine as much as possible. So try to push ourselves, do the things as and when it comes. So try to keep a healthy routine, which can have a positive impact both on your thoughts and feelings. The sleep, next one. So get enough sleep. The biological clock is very important. Stick close to your typical sleep wake cycle. That is, sleep at the same time at night, wake up at the same time. That is the biological clock. So if you keep this routine, even hello, can you hear me? Did it get disconnected? Hello? You're on mute. Can you unmute yourself, please? Yeah,
can
you're
continue,
able to
ma'am.
hear.
Yes,
Okay,
ma'am.
okay,
Yes,
yeah.
you can continue.
Okay, okay, yeah, thank you. Okay, the next one is physical activities. Regular physical activity and exercise can help reduce anxiety and improve mood. This is before. Now, see, post-COVID, already Madam has covered about the pulmonary rehabilitation, what is supposed to be done and what is not supposed to be done. So that has to be followed. This is to keep a healthier mind and physically. So physical activity is very essential. Next is eat healthy. Choose a well-balanced diet and limit caffeine and nicotine related substances. This is very important because this can aggravate stress, anxiety, and sleep problems. Because I see a lot of patients having 3-4 cups of tea or coffee, which can actually reduce the sleep, which can worsen the anxiety and the recovery time. So ask the patients to limit certain substances which are stimulants, also to avoid tobacco, alcohol, or any means of drugs which is harmful both for the physical health and the mental health. Next, coming to the screen time and minimize news feeds. So when a patient is admitted in the hospital, then we see they are more involved in the, if they're fine, they're involved in the phones or checking the news, trying to browse about the COVID illness itself, which will worsen and make them more and more anxious. So tell your patients to limit the screen time. Yes, they need to be updated with the latest information, but ask them to keep a specific time of a day, once or twice, and a reliable sources. You help the patients to find out a reliable source of information, what they're supposed to know and what they're supposed to ignore. This can help majoritarily to reduce the anxiety and the distress concerning the illness itself. Next is the relaxation techniques, breathing exercises, and meditation. This is a very healthier way. Usually, the professionals, like even the clinical psychologists, help with the relaxation training, breathing exercises, JPMRs, meditation, a healthier way to cope up. Next, identify, label, and accept your feelings. This is very important to know. Observe yourself to understand how your thoughts and emotions are impacting you so that you know when to seek help. Tell your patients to observe. It's not like constantly they sit and observe, but acknowledge if they are feeling if they are experiencing anything unpleasant or uncomfortable feeling when in the hospital. So ask them to speak up. Ask them to speak up to you. Be a good listener. So it will help. And then ask them to adapt a mindfulness type of exercises, which usually the clinical psychologist will help. It can help us stay grounded in the midst of an emotional storm. You can learn how to witness and learn the thoughts and feelings which come and go in their own time without getting overwhelmed by them. Learn to communicate effectively and connect and interact with your family. I know when a patient is admitted due to COVID, usually the family members are not allowed. It's the patient alone and the nursing team, the medical staff will be there. But ask the patients, allow them to contact at least through phones, screen, share your concerns, ask them to share the concerns with the family members, discuss their thoughts. It is important to take others' perspectives too, to know if they're perceiving things the way they are feeling. And next is follow safety tips. That is, learn about the facts and information from reliable sources and find out the tips to keep yourself and your family safe. In case if the patient is still not able to find easier with all these measures which has been adapted, then ask them to speak up and take a professional help, that is the psychiatrist, psychologist, and the team. So now when a patient comes up with these, what is the role? It is the multidisciplinary team which takes part in the mental health. So we have to first diagnose the patient if the patient will require a pharmacological treatment or only the non-pharmacological treatment is sufficient. So it depends on all the factors, that is the biological factors, the psychological factors, the social support. So everything taken together, a plan is created for the patient. Okay, if pharmacological treatment, so the antidepressants, selective serotonin reuptake inhibitors, or the other classes of drugs, which class to be used. That all depends on the comorbidities of the patients. Earlier, what the patient was treated with, if it was effective, and he has or she has shown good improvement with that particular medication. Was there any adverse effects following certain medications? That also has to be taken. What are the other mode of treatments which can be delivered to the patient? So everything is a collective effort. Along with it, the psychologists can put their views on the therapies, which is the cognitive behavioral therapy. It all depends on the patient. If acutely ill patient, we directly don't jump into the cognitive behavioral therapies. We allow them, supportive therapies are given, and then once slowly in the recovery phase, so the level of the treatment is gradually increased and supported. This is very important. That is how one has to think about the suicide or the self-harm, how to cope up with these thoughts, being in a mental health professional, the nursing staff, how they can quickly pick up when a patient comes up with these negative feelings, because the patient most of the time is spending time with the nursing staff, that is because of the care. So they'll be comfortable in speaking out to the medical health professionals. So what are these? So whenever you get to know that the patients are having negative feelings, which are becoming overwhelming, reach out for support and help. Know the warning signs. I have given some few warning signs in the next slides, which has to be picked up. Pay attention to the way a person talks and behaves. This is very, very important. So when a patient comes, ask to the family member how the patient was before, and is there any changes in the way the patient is talking? Is it much less than how the patient was before? Earlier, was he jovial and now it's very silent? Or very anxious, crying or tearful? Is it the same way the patient used to cope up? Talk to the family members, get to know about the social circumstances so that quick actions can be taken up, and in a holistic way, the patient can be treated. So what are the warning signs when a patient starts talking about death or suicide? Don't take anything as a joke. Don't take anything as a simple way. Okay, he's just saying that it's better to die. There's no point living. So many of the patients would have told, or many of the friends would have told, just don't take it lightly. Just ask them, allow them to speak up, allow them to express the feeling, be a good listener. See if they are showing the signs of hopelessness, helplessness, if they are having negative thoughts, pessimistic thoughts about the future, uh, saying that they are burdened to their family, to the society, or they are very worried about how the illness is going to take. It's better if it ends all in all. If they have started avoiding friends and family, started avoiding to talk or interact even to the physicians, the nursing staffs, just be alert and take out these signs and keep in mind that okay, there is some mental health issues which has to be really taken care of. Know about the pre-existing mental health illnesses. If the patient was suffering with depression, was there a previous suicidal attempt or a self-harm attempt? Just try to find out. Okay. If the patient is trying to give away possessions, if the patient says that no, I have made a will, I think it's my time, I have to give everything, my possessions to the family members. Just have a look why the patient is telling these, or saying goodbye to the family and friends, or losing interest in activities. So be alert when a patient comes up with these warning signs. So physical distancing in itself can make the warning signs harder to observe. So try and check in regularly to see how they are coping, especially those with a history of suicide, depression, anxiety, or other mental health illnesses, or those who have experienced a recent loss. Supportive and being supportive, even family members, the adults, can play a critical role in the lives of young people at risk for suicide. So listen, this is very, very important. Suicide is preventable. So listen and do not be afraid to talk about suicide. Suggest that they seek professional mental health support or help them connect to support system. Uh, the government has come up with a lot of helplines, and even the private institutions have come up. Medical health concerns people are asking. So even for the mental health, there's a helpline by the government of Karnataka. So with this, I would like to end my session. Thank you. If there's any questions, kindly ask me.
Participant, please note it's time for discussion. Please raise the questions. You can unmute yourself. No questions. No? Okay. As there is no questions. So, thank you, ma'am, for your wonderful session. It was really thought-provoking. Thank you, ma'am.
Thank you.
Now we have come to the end of morning sessions. We will rejoin the webinar at 1:50 p.m. for afternoon sessions. Thank you.
ಅವರು ಇದ್ದಾರಾ? ಅವರು ಜಾಯಿನ್ ಆಗ್ಲಿಲ್ಲ?
Hello, hello.
Good afternoon to all. We will begin with third session. I am glad to introduce Mr. Prasanna Kumara, nurse practitioner in critical care, Kasturba Hospital in Manipal. Mr. Prasanna Kumara completed his BSc Nursing and MSc in Nurse Practitioner in Critical Care Postgraduate Residency Program from Manipal College of Nursing. He has organized skill training program and webinar for nurse practitioner and critical care nurses. He also conducted national and international wide training program for critical care nurses. He is collaborated with Department of Critical Care Medicine team. He conducted continuing education for nurse practitioner PG students and critical care nurses. He has given the development of nurse practitioner career description, guidelines and institutional protocol and policies. He has 5 years of clinical experience in trauma and critical care nursing. He has won the state and national award for emergency rescue in the year of 2011. He is the first person to complete nurse practitioner in Manipal College of Nursing from Karnataka. A warm welcome to you, sir. Over to you, sir. So you can start the session, sir.
You can start
Hello, madam.
your session.
Hello.
Start, sir. You can start, sir.
May I audible? Hello, ma'am. Can you able to hear my voice? Hello, ma'am.
Sir, can you please unmute yourself?
Hello.
Yeah,
Hello.
so we can continue
Yes.
your session.
Yeah. Thank you. Thank you. Good afternoon, all respected madams, sir, and the nursing professionals. Approximately, nurse practitioners, 300 nurse practitioners working across the country in various critical care units. Currently, fourth batches of nurse practitioners passed out in India. So we all know nurses are at the forefront in the fight against the COVID-19 worldwide. Let's start the session on problems, challenges, and role of nurse practitioner during the COVID-19 pandemic in India. Next slide, please. Madam, could you share my slide? Hello.
Sir, you are audible. You can continue your session.
Yes, sir. Please share my slide. Go to the next slide. Yes. Let's start the session on problem, challenges, and role of nurse practitioner during COVID-19 pandemic in India. They work around the clock to offer constant care for critical ill patient. The year of 2020 was designated by the World Health Organization as the International Year of the Nurse and the Midwife. In the next slide, we'll see statistics of COVID-19 pandemic in India. Previous slide. Previous slide. Come. Yes. COVID-19 pandemic in India is a part of worldwide pandemic of coronavirus disease caused by severe acute respiratory distress syndrome. India has the second highest number of confirmed cases in worldwide after the United States of America. COVID-19, which originated in Wuhan, we all know, People Republic of China, has spread to all parts of the world. Increased travel around the world and globalization accelerated its spread across the countries. In India, the first case of COVID-19 was reported on 30th January 2020 in Kerala. As of today, 4th March 2022, Ministry of Health and Family Welfare statistics says there were 4 crore 29,050 4 crore 21 lakh 51,556 confirmed cases, out of which 69,897 were active cases, 4 crore 23 lakh 67,070 cured by discharge, and 5 lakh 14,589 were reported deaths in India. India has the highest number of confirmed cases across the Asia. So now total 224 countries plus territories around the world have reported a total of 44 crore 24 lakh 6,885 confirmed cases and 60 lakh 1,833 deaths. In India, Maharashtra is the highest COVID-19 cases and deaths were 1,43,718. In Karnataka, currently today, statistics which is telling cases 39 lakh 41,835. So death rate 39,979. So let's see what are the challenges faced by nurses, which are listed here. First important, during the COVID-19, when it started in India, so we are unprepared about COVID-19. So challenges what we have faced: lack of PPE, high workload, mental health problems, low social acceptance, lack of incentives, lack of coordination and direction, coping strategies. This all we have faced as a nurse practitioner, part of the nursing professionals. Many of them, they fighted against the COVID-19 diseases. So we'll see one by one in next slides. Lack of personal protective equipments, insufficient personal protective equipments, inadequate training to deal with COVID-19 patients, lack of accommodation, food, and transportation facilities for nurses, and separate screening, quarantine, and admission facility for nurses in hospitals. As per the literature and early COVID-19 diseases, we all know about paucity in quantity and quality of PPE 60%, lack of training in protocols about donning of PPE 75%, and reuse of N95 mask 85%, increase the rate of infectious among the health professionals. Medical supplies were first to be negatively impacted during the pandemic, especially masks, protective gears, and ventilators. Notable in developing countries, medical supplies were not stocked for more than few weeks at this time. The nurses and nurse practitioners are committed to serve the society, and biggest challenge of faces is to cure and care for the people affected with COVID-19 diseases. Wearing a PPE for a long time resulted in decreased oral intake in terms of food and fluid, sweating 86%, and holding of urine and feces 75%, which further had deteriorating effect on health and immunity. So, health professionals are challenged by a lack of pandemic preparedness, scarcity of clinical supplies, and implementation of social distancing. Many healthcare professionals felt that there is an institution had adequate access to use PPE, but were unwilling to share it freely due to of fear of future shortage. In response, many hospitals elected to reuse disposable items such as masks and gowns, which ultimately led to significant concerns about safety among nurses and nurse practitioners. Next slide, please. Next is high workload. Excessive workload and fear about health of family members also lead to a stress which manifest as insomnia, increased physical weakness, fatigue, decreased immunity, increased susceptibility to infection. During this pandemic, COVID-19 pandemic, healthcare workers were working tireless day and night to cater their service to COVID-19 patients. Unfortunately, we lose many of the workers to the pandemic. Next slide. Mental health problems. Insufficient workforce funds, fear of infection to self, loved ones, and increased mortality data also lead to increased stress and deterioration of mental health. Who were involved in care outside of their usual area of practice experienced higher level of self-reported stress. They were experienced anxiety attacks as well, frustration due to lack of knowledge, environmental changes, and fear of infection both by themselves and their family members also, such as psychological abnormality related to work pressure, dissatisfaction, exhaustion, long duty hours, and lack of appreciation. This is all comes under mental health problems. We'll see in the next slide low social acceptance. Low social acceptance, nurses and nurse practitioners caring for a patient during the pandemic, performing additional duties or practicing in unfamiliar area greatly enhanced the risk of exposure for nurse practitioner and lead to concern about the possibility of decreased quality of care. Unfortunately, due to the concern of viral transmission, many healthcare professionals separated from family members, even we, elected to physical distance themselves from family members at home or left their home together. It wasn't just stress of patient that were feeling, but stress ourselves with our own families. Continued media coverage on television and social media seems to influence healthcare professionals' relationship with their patients. So next slide, come to the lack of incentives. Lack of incentives, initially there was no monetary incentive for the healthcare professionals, especially in corona warriors working in government or private facilities. If they got infected or died during the service, nurses, nurse practitioners were aware that there was no extra incentives for them despite of working extra hours. Some incentives were promised by the government or private sector, such as providing treatment cost in case of patient nurses got infected, and providing an isolation room to ensure safe inhibition. Next slide, ma'am. So here, lack of coordination and directions. According to WHO, World Health Organization, and government guidelines were changing continuously given the disease is new and previous knowledge is little. In several cases, healthcare professionals and especially nurses got infected because a patient did not reveal that they are COVID 19 positive or they are COVID 19 infected. Yeah, high level coordination failure was prevalent in the healthcare administration. The biggest challenge faced were to be flexible with changing protocol, nursing training, and wearing a mask for several hours together. We can see in the picture. So when establish the proper COVID-19 protocol and guidelines, which is going to helpful for the best coordination, it is useful for nurses and other healthcare workers. So move on to next slide. Coping strategy. All the nurse expressed that belief upon God kept them relaxed. Yes. Support from family members and colleague was also essential coping mechanism. The nursing professionals maintain regular conversation with colleague, maintain social distance, and try to be benevolent with each other in their workplace. Apart from taking mental support from friends and family, LK professionals try to follow every medical rules and regulation in their ability to keep safe from infection. Next slide, ma'am. Nurse practitioner roles and responsibility. Nurse practitioners have critical role and responsibility during the COVID-19 pandemic. They will continue to be at the front line patient care in hospital and actively involved in evaluation and monitoring in the ICU. Nurse practitioners have to ensure that all the patient acquire personalized high quality service irrespective of their infectious condition. Nurse practitioner must maintain effective supply and usage of sanitation, materials, and PPE, personal protective equipment. They are able to see what is working as well as things that can be done differently to provide more effective care and offer suggestions for improvement. So this all responsibility we nurse practitioners have. So let's see in next slide. Nurse practitioners have an active role in prevention and control of communicable diseases, especially in COVID-19 pandemic, which include identify sources of infection and method of spread of infection, health education of people in general, notification of COVID-19 to the health authority, teach and supervise other healthcare in surveillance activities. So I have mentioned here few roles of nurse practitioner in COVID-19 pandemic. Next slide, ma'am. Nursing or nurse practitioner must include guidance to nurses and support personnel on emergency COVID-19 problems and hazards that are unique to their field of work. First point, patient care. So when we are doing patient care, quick assessing a patient condition, the spread of infection can and often is drastically limited. Patient who tested positive or shown symptoms are quickly moved to quarantine, protecting from others patient who may not have the diseases. Those symptoms which provided by the CDC Center of Disease Control for the coronavirus diseases include as symptoms includes fever, cough, shortness of breath. So based on the severity of illness, follow the guidelines which provided guidelines Ministry of Family Welfare, ICMR, All India Institute of Medical Society guidelines. Managing medical supplies. Second point. Social distancing technique designed to prevent coronavirus from quickly spread out within the hospital setting. Another role of nurses play during a pandemic is very maintenance supplies of medical equipment and protective items such as mask, gloves, and sanitizer. These resources can be easily become scarce during a crisis, and nurses play a vital role in safeguarding these supplies from theft. Proper sanitation is one of the most important factor in turning the trade of turning the tide of a pandemic. Virus such as COVID-19 can remain on a surface, we all know, for an hour, sometimes longer time, making an regular through cleaning a life or death necessity. Because nurses who work so closely and so regularly with the patients, it often fall on them to enforce sanitation rules and procedures. Third point, during a pandemic, enforcing sanitation. During a pandemic, nurses can expect to work longer shift, especially as the virus spreads and healthcare workers themselves fall ill. In some states, such as Maharashtra, you can take an example of Maharashtra and Delhi. In the first wave or second wave, beginning the time, which is a highly peak cases we have noticed in this area. Currently, statistics were telling Maharashtra and Kerala is the highest number of the COVID-19 positive cases. Nurses are even being asked to turn to work from the retirement to help fill the need. So most of the nurses are going to give a retirement. So we are unable to do a work because of a lot of frustrations. Fourth point, working overtime. So nurses must teach other everything they practice from symptoms awareness and sanitation to disease prevention. As the front line of healthcare, nurses bear the additional responsibility of educating their patients and general public on how to stay healthy and prevent the virus spread of virus from the spreading, prevent the virus from the spreading, while information on the thing like proper hand washing, social distancing, and sanitization can be found from many sources. Nurses have a more powerful voice than most. Next slide, ma'am. At the last conclusion of session, yes, nurse practitioners are important in managing a health crisis because of their vital link between the patient and nurses and rest of the healthcare workers. Nurse practitioner relay their assessment findings to provider. They are able to determine if respiratory therapy needs to be called. They are able to do the assess the patient responsible to medical treatment, and they are educate or counsel the patient and family members. In Manipal, nurse practitioners are now actively involved in COVID-19 interventions, and they will remain key player in the COVID-19 ICUs along with the critical care unit with adequate interprofessional assistance. All we can do is try our best, express our sincere, heartfelt gratitude to these brave healthcare workers. Thank you. Thank you all. Over to you, ma'am.
Thank you, sir. Participant, it's time for discussion. Please raise the questions. Any questions? There is no questions. So thank you, sir. It was really thrilling, challenging experience. Thank you, sir.
Thank you, ma'am.
Let us move on to the last session of the day. Now I request Mr. Sushma to introduce Ms. Sridevi Balachandran.
Good afternoon to all. Ms. Sridevi Balachandran has been working in Oman at Sultan Qaboos University for the last 18 years. She has completed Masters in Cardiothoracic Nursing at Leelabai Tarkarsi College of Nursing, SNDT Human University. She has worked in PD Induja Hospital for 5 years. She spent clinical year at Royal Brompton Hospital, London, and other large heart transplant centers in London and nearby areas. In a short while, her leadership potential were tapped and she joined the Manipal Hospital, Bangalore as a first director of nursing. There are many sweeping changes to her credit, some of them being establishing a CNA program which is continuing from 2000 to date. Professionalism instilled among nurses, non-nursing functions eliminated, introducing convenient professional looking uniform, infection control department, patient safety requirement, etc. She has been awarded the best teachers in 2012 at Sultan Qaboos University. She has research and concept paper to her credit, and she has been resource person in various conferences in India and internationally. She has completed an online certificate course in fundamentals of peer review from Elsewhere Academy, as well as certificate course from QMIT Knowledge Foundation on information resource and the literature searching and mastering PubMed, as well as completed an introductory course in systematic review from Johns Hopkins University on Coursera. I am indeed glad to welcome you, such an outstanding personality. Over to you, ma'am.
Thank you very much to everyone and greetings from Sultan Qaboos University, Oman. Thank you to the principal, Dr. Larissa, the organizer, Diana Lobo, Shushma, who has been contacting me. I will share changes. Can I share, please?
Yes.
I will share my slide. I have made some small changes. Uh,
Okay, ma'am.
yeah. So, where is it? Google Slides, your computer. Okay. Um, where is the desktop? Extremely congratulations for organizing this workshop, and uh, you have been perfectly on time. It's weekend for me, and it becomes a little hectic for me to take up such kind of uh, activities. But however, I enjoy talking to the future of nursing, and hence you can see me here. Just a little bit guidance is required. Now, my slide is on the desktop. What do I do?
Share.
Share
I have,
slides.
yeah,
Share
share
slides
slides. I've already gone to share slides. It's asking me where are your slides.
from your computer.
Add file from my
Computer.
computer.
Yeah.
Yeah, okay. Using Keynote. Okay, upload file. But where is my file now? Why should I upload the file? Okay, no problem. Okay, can I share this again with Shushma? Is Shushma available close by?
Yes, ma'am.
Okay, I just share this file because I made changes. Just open it from your side. It will save me time. Okay, let me just reply. Sorry, because I thought I needed some more time to change things. Okay. Yeah, I've shared the slide. Can you please open it? It's coming through. Yeah. Just check your email, Shushma, please.
Yes, sure, ma'am.
Yeah. Okay. In the meanwhile, I can start. Thank you so much for organizing this kind of a conference, and I understand that this is done by the Nurse Practitioners Critical Care Program of Lakshmi Memorial College. I'm glad to be here speaking with Prasanna and the other colleagues, and I'm extremely sorry for having missed some of the things that were spoken here. Anyway, to start with, the topic given to me is problems, challenges of nurse practitioners or nursing professionals in COVID-19 abroad. Now, I would like to have you received the
Yes, ma'am.
yes,
One
okay,
minute, ma'am.
no problem. I just want to tell everybody here that yes, I am, if you're considering my age and experience, I'm sure you should know that I have no direct COVID experience, but I have collected enough information for people to understand from literature as well as from my friends or personal contacts from three different countries, especially from UK, Canada, and the place I am in directly, that is in Oman. So these places I have directly got information. But I'm very, very sure if you listen to Prasanna very carefully, the challenges and problems that people have or nursing professionals have may be no different, except when I was preparing my own slides, I thought something about resources may not have been as challenging abroad as in India. For example, in Oman, they probably did not, in the country I am in Muscat, they did not have resource issues. In fact, they had other issues. They donned and doffed so many times because everybody has human needs. So it was not as strict as probably in India, where once you get into PPE, you will have to stay like that for 6 hours or 8 hours, or sometimes even for a long period of shifts without uh, having to even go to the bathroom or use meet your basic needs like drinking water. So I have no direct experience, but I will start with the information that one of the most important challenges that we have had in COVID-19 is basically related to our professional identity. Nursing will never be the same again, ever, from now, from post COVID times. It will never be the same again, because we have now learned to live and to be identified and to face challenges in a very, very different manner. Next slide, please. Is it clear to everybody? Can you see it? Okay. So this was my disclaimer, a slide that I had put, that I have collected information. Yes. And I have no direct experience of dealing with COVID patients, and that should be Prasanna. So if you've heard Prasanna, I think he will echo a lot more authenticity than I will. Next slide, please. So the pandemic has strongly influenced what is called as the professional identity of nurses, and I'm going to speak about it in a minute in the next slide. It has definitely affected nursing education and nursing research. So if you look at the professional identity, what we are talking about, the critical issue for nurses was basically related to issues such as nursing roles. I mean, you look at what happened is roles and responsibilities changed. So if, for example, I'll just give you a small example, that if I'm from critical care background, so that's one good thing to know about. So my role and responsibility is to deal with critical care patients. But if I happen to be of the age that I'm not safe to look after critical care patients, then I may actually be moved out of the ICU and have to deal with maybe medical ward patients or surgical ward patients. And similarly, an operation theater nurse, actually in our hospital, operation theater nurses were redeployed into critical care units because the staff fell sick and we had inadequate nurses to look after patients. So this kind of change in roles and responsibilities is huge, because normally after 5 years or so, usually nurses don't change their roles and responsibility. It's only in the initial stage that we change our jobs and try to find out what we like. Okay, it also was a challenge to values and ethical standards. So when you say values, like we as nurses use touch as a therapy, and we directly communicate with patients face to face. If a patient can talk, we do not use plastic shields and aprons and be inhuman to patients while we talk to them. It is not our value in nursing. And similarly, ethical standards. Patients are dying left, right, and center. Before we even completely pack up one patient's body, another patient is already on the bed. or there were times when it's not in Oman, but I'm sure in many Western countries you would have seen WhatsApp videos where decisions were made who will get a ventilator and who will be left to die without getting a ventilator. These are huge ethical challenges that actually affect our identity as nurses, because we are not people who do these kind of things, so which are unique in the nursing profession. These are all unique issues. Then the other thing that we had a problem with was physical and emotional stress, and I'm sure this was already spoken about. I cannot imagine being in that PPE kit for even half an hour, because I have reached a stage where I cannot even imagine half an hour, forget 6 hours, 8 hours. I understood that young nurses who did this, and I salute them from my bottom of my heart, everywhere in the world as well as in India, for staying in that PPE kit even for 6 to 8 hours, while I'm told that people have done 12-hour shift and sometimes even 3 shifts because there were no staff nurses to look after. In many cases, it has been reported in literature. So physical stress and emotional stress of our own personal life, that means having to go home and being afraid of transmitting this infection to elderly people who already have some morbidity and mortality, or to your own children, or to your families, as well as seeing patients die every day, packing them up in a very unusual manner, not allowing relatives to see even the dead body. This could be huge emotional stress for people, for nurses. Then there is also moral distress because of the conflicts that are happening in professional practice. There was high levels of acuity, patient deaths, and long working hours, and these must have caused our very being to shake, because imagine not getting accommodation, being thrown out of your accommodation because you're looking after COVID patients. All these are not unusual stories. But however, these are this kind of accommodation issues, etc., like probably happened in Bangladesh or in our neighboring countries, but there was not much said in the literature about Western countries. Nor did our friends in UK or Canada, where I have friends I spoke to, they did not have to face these kind of problems. Large number of nurses were infected and separated from their loved ones, or they actually sacrificed their lives. So these are the issues in professional identity that I wanted to highlight. There's a full paper on how nurses' professional identity has been affected, and the reference is below. Next slide, please. Nursing, I would try to finish this in 40 minutes because I don't want to keep anybody. I'm the last speaker. I did not put my timer on. Okay. In the professional identity, there is another paper that specifically Morley et al. Reported challenges that is that negatively affect our professional identity. And the 3 ethical issues that they spoke about was safety of nurses, patients, and their families. Then the allocation of scarce resources. If you have one PPE, does the doctor get it? Does the nurse get it? Does the cleaner get it? And it was very clearly documented, because nurses have to be there anyway. All the work that the other people had to do was dumped on the nurses. So the doctors never came into the unit, and you were probably seeing them on a tablet or making your own decisions on managing the patient. Including the cleaners did not come because of allocation of, resources were very scarcely available. There is, even the bins were emptied out of the unit by nurses. So this actually affects your brain totally. You kind of think, what am I doing? Am I a nurse, or what is my work? That kind of a situation it would have reached because of the allocation of scarce resources, using diapers, not being able to drink water, sweating it out. All these become a problem, and it affects us emotionally. The changing nature of nurses' relationship with patients and families. Nurses are the most trusted people in all polls that have been done in Western countries. And while now in COVID, they were not able to show their trusting relationship for patients, talking through plastic covers, etc., are affect relationships, and this might actually negatively harm our image of nursing, because nursing is a caring profession. It uses a lot of caring aspects, and the way we had to work during the COVID times would actually damage a lot of relationship and image of nurses among the patients. Next slide. I put only one slide on nursing education and research, because those who are students and who are listening to me will know that in the last 2 years, we have been doing online teaching. And I currently am teaching a group of critical care students who did adult 1 and adult 2 online, and it's unbelievable how negatively online education actually from a teaching perspective has affected the students. The students who are going to graduate in the next, by August, I should say, this is already February, students who are going to graduate by now, August, these students basically have no idea even of what is what is FiO2 or what are oxygen devices. They are not doing their health assessment or using their stethoscope correctly to auscultate the lungs. So yes, we kind of educated because we cannot stop education, and then again there will be shortage of nurses, but this definitely has harmed nursing education and standards of education. Many people have written papers. This was a very good time for all the people to write papers on simulation, because simulation is the in thing, and simulation used case-based scenarios, and most people who are for simulation have reported that this actually enhanced the preparedness and learning effectiveness of, and reduced clinical stress. Great, it reduced clinical stress, but how much of clinical learning was missed by staying in a lab or doing a simulation? This is not something that people have reported, because when a paper is published, usually people do not write a large number of limitations. So simulation was used. But in India, I know, because I have friends in Bombay and other places, senior nursing students, initially students were not doing COVID duty, but later on students of the final year definitely have participated in COVID duty. Master students have participated in COVID duty, and it has been reported in papers published that nursing students perceived clinical nursing work as too dangerous, especially in the Western countries. People didn't want, nursing students did not want to engage in nursing as a profession because of participating in COVID-19 pandemic. And actually nearly 10% of students expressed an intention to leave the nursing profession because they were exposed or they worked during COVID-19, and these young students perceived it negatively and not really positively. This may not happen in India, but even then there may be parents who have questioned students' decisions on whether they really want to be nurses working under such conditions because they were asked to work in COVID-19 units. So that's about education. However, research has been positively, everybody took the chance to actually use COVID-19 as a big publication opportunity. If you go up to any search engine, you will find hundreds and hundreds of articles, even related to nursing, medicine, to every subject, on publications that have been made because it was COVID-19. So COVID-19 has positively impacted nursing research, and many aspects of knowledge and care were studied by nurse researchers as well and published. So this is nursing education and research. Next slide, please. So now I will go to actual problems and challenges that were reported. As I said, I've taken approximately 7 countries, and the first country that I have, this is actually the paper that was published, and these are all from very good journals. I don't know how much clear the paper may be to you, but however, in our neighboring country, in Bangladesh, a paper that was published basically looked at the problems that participants that experienced, and that was higher workload. I'm sure you can relate to this. Psychological distress, as we explained, it could be with personal life as well as dealing with patients who are dying, or patients who we cannot help because there is lack of equipments, or they are outside and we are not even able to do something, because we as nurses are trained constantly to provide help and care even at the cost of our own life. So psychological distress could occur because we are trained to assist and help people. There was shortage of quality personal protective equipment. Yes, it happens to be Bangladesh, so it will have similar issues like India. Okay, there can be social stigmatization, lack of incentives. This is something that many countries have reported. But I heard from my friends in private hospitals in India that there were quite a few private hospitals, especially from Bombay, etc., who paid 800 rupees per day extra to nurses for their COVID duty. Some people paid 250, and there were some people who didn't pay anything at all. And this can happen. India has never had a common standard of practice or remuneration for nurses. So this is something that you can look at. So lack of incentives, absence of coordination, chaos, because this is reported from UK as well. Morning they will tell you wear normal mask, afternoon they will tell you wear N95 mask, evening they will tell you wear PPE, next day they will tell you no need of PPE. WHO itself kept changing its issue, I mean the guidelines. So there is a lot of issues for coordination, and at the floor level, in the clinical level itself, there must have been a lot of coordination issues because people fell sick, number of patients that you have to deal with are more, equipments are less, so there was a big demand supply gap, and this would have caused a lot of absence of coordination and proper management during their service. The nurses service, they were not given adequate leave. These are same things, I'm sure you know, you did 7 days, you got 7 days off, slowly it became 7 days, and then 2 days off and 3 days off, and then everything went back to normal because we did not have adequate staff to work on COVID duty. So everything was forgotten, and probably you overworked yourself and got less off. Next slide, please. So that was Bangladesh reporting there from on an article that was studied in and published here. Next slide, please. Hello. Yes, the next study that I'm talking about is, the next 2 slides are coming from Iran. Iran is a neighboring country to Oman here. The article, I mean, a study that was published in Journal of Health Education and Health Promotion. It talked directly about challenges faced by nurses while caring for COVID-19 patients. It was a qualitative study, so they studied only a few nurses. So they had this 3 main categories and 17 subcategories. So the main categories consisted of mismanagement in controlling corona conditions. What they meant by this was that there was not adequate awareness, or there was no vaccination drives, there was not enough information given to people where they should go. So there was a lot of mismanagement of what was happening around corona with public, and this directly affected the hospitals. Then mental and physical complications and challenges in corona conditions, that is for the nurses and the healthcare staff. They had problems with them, and there was definitely lack of sufficient workforce, either because the staff were falling sick or there were too many patients and not enough nurses to handle patients. Next slide, please. So the subcategories or the details of this were given in the slide here. They talked about fake data, releasing misinformation and fake data. This same thing we suffered in India as well. People tell you take ginger and garlic and drink hot water and put some powder in your nose and you will not get corona. And people did this instead of going to take vaccines initially. There is injustice and discrimination. This any organization commonly has. There was lack of direct supervision over prevalent by authorities and by authorities, and this caused dissatisfaction among nurses. There was financial and emotional support for nurses that was not there. So this is same thing like Bangladesh, that there was no financial and emotional support. There were not enough measures to impose complete isolation of COVID-19 patients. So we don't know which patient has COVID and which patient doesn't have COVID. And by the time we do this, and this is same thing of this isolation issue, you will find even in UK. So in UK, they had a problem that it took 3 days for a COVID test result. By the time COVID spread to the patients in the ward, or it spread to people in their families, and this becomes a chaos. And similar things happened in our hospital here where I work, that there was COVID everywhere, because by the time you get the result, the patient has already, the whole ward has had this aerosol generated, and this is going to cause a problem. Nurses' fear and anxiety for working in corona conditions. This was only an initial thing, but nurses really were resilient, and that's why I'm saying I salute. I appreciate that when it came to really working, all the nurses got together. There was no major problem. There were occasional problems reported that some nurses refused to work in the corona units, but in our hospital here, they did rotations. So 1 month they worked in the COVID ICU, and 1 month they worked outside the COVID ICU. So this was managed administratively. So everybody got a chance to work in the COVID unit and also outside the COVID unit. But there are differences that we should know from India to my hospital where I work, because here we work as expatriates or as people not belonging to the country. So there are always some pressures that, and we cannot defend all the time and say we will not be able to work. At the same time, local people might have more facilities given to them, so this looks like a little discrimination. So not that it happened, I didn't hear anything like this, but these things can happen when you don't work in your own country. But even in your own country, there could be discrimination of some sort or the other. I didn't read much about Indian COVID challenges, and I really missed Prasanna's presentation. So difficulties using personal protective equipment, not following standard protocols in corona conditions. So for example, doing CPR, there must be a standard protocol, but when a patient has corona, it was very important that nurses protected themselves, because we have a duty to care for ourselves. So the CPR must have become delayed, and nurses have to be counseled. Actually, this is what the literature reports. Had to be counseled. It's okay, we cannot save every patient, and we need to protect ourselves. And this had to be taught or ingrained into the nurses, because nurses were jumping in to make sure that patients were safe, irrespective of their own safety, without taking care of their own safety. Workforce crisis was there, equipment crisis was there, and this happens. Iran is just very close to our place here in Oman. So these were the things that were reported. I'm sure this is the same. At the end, I would like to ask Prasanna to comment on what I have spoken. Next slide, please. So that was Bangladesh and Iran. There's a study from Brazil on nursing challenges in the face of COVID-19 pandemic. And this Brazilian study reported that the Brazilian Nursing Council received more than 3,600 complaints about poor quality PPEs, masks, gloves, and apron. It is the same whether it is India, Bangladesh, Iran, or Brazil. There was shortage of workforce. There were pressure injuries that were reported. This we have seen enough on the WhatsApp, how the nose and the face of these nurses who wore N95 masks looked like. There was inadequate guidance. Nobody taught. But in most of our places, as in Oman and UK, etc., as I heard from my friends, there was infection control department very active, and they taught nurses how to use or how to do donning and doffing. But Brazil reports inadequate guidance on how to deal with COVID-19 donning and doffing of PPE. There was low recognition. This is the third study that is showing you low recognition and rewarding of health professionals. There was double or triple shifts reported by Brazil. That's really sad. Triple shifts means 24 hours working in PPE, but it was written there. So that's something that I wanted you to know. So sometimes we might feel very positive. Okay, I did only a double shift and not a triple shift like nurses in Brazil. And nurses had to self-isolate themselves. This is the same thing I have heard even in India. You didn't go home, you stayed in hostels or in accommodations because you didn't want your family to get infected. So this is Brazil. The next country, please. The next country is Egypt. This comes under South America. And this study is very interesting, because this study actually tells you, okay, staff nurses had all these problems that we saw in the last 3 studies. But this study talks about challenges facing nurse managers. So shift in charges, head nurses, and above the administrators, what kind of challenges they faced during the COVID-19 pandemic, and what was the recommendations. The implications are here below. But what were the problems that the nurse managers faced? Because it's not only nurses. We think the nurses are the only ones who face problems. No, because the nurse managers or their administrators were equally around to somehow, though they did not provide a lot of adequate support as the staff nurses may feel, they also had a problem of lack of training, community image, no monetary rewards, uncomfortable atmosphere, staff morale. When everybody starts crying, gets angry, or stops coming for duty, then this brunt of this whole problem goes on to nurse managers. So keeping staff morale, rumors. Oh, this one got COVID positive, that one got COVID positive, this happened, that happened. So if something didn't even happen, people put out rumors, and to put these rumors out or kill a rumor is a bigger problem than actually a problem that occurs. So solving too many problems at one time, violence against healthcare workers, the nurse managers themselves did not get support. There was a lot more of a lack of community awareness, communication problems, because management cannot happen without communication, lack of qualified staff to staff their units. These were all the issues that were reported by this study from Egypt, and they recommended that nurse managers required more structural and emotional support, assist in problem solving, and ensuring safety of care professionals. So they needed more support on these issues. Next one, please. Now I'm coming to my personal experience. So those were 3 countries. Then I talked about nurse managers. Now these are real life incidents. This is something that I'm telling you from my hospital, Sultan Qaboos University. So in our hospital alone, we are one of the biggest hospitals in Muscat. There are multiple hospitals, and but we are a referral center and a tertiary care center. In our center during the COVID-1 and COVID-2, there were approximately 196 admissions into the critical care unit. The hospital divided the critical care unit into 2. The old ICU became the COVID ICU, and then they took a ward and made it into a new ICU so that regular patients who require care could be kept in a non-COVID ICU. But this statistics come from the COVID ICU, that there were 196 admissions in the critical care units. There was 123 patients that were safely transferred out of the ICU. However, there were 69 deaths, which is like almost 1/3 of the patients died. 1 by 3 patients died, and 4 patients who went out of the ICU came back to the ICU for readmission. I have seen patients who went out of the ICU because I was teaching in the wards at that point of time. There are patients who have had complete paralysis, neck down, patients who have had tracheostomy for 3 months and 4 months. People thought it was GB syndrome, but even plasmapheresis did not help the patient. So obese patients were hit much more harder in my observation than patients who were not obese. Now, this is reported by the head nurse from the COVID ICU in our hospital. So they had this problem that patients who came for admission were not, they were kept, the nurses had to go through a lot of exposure time, because by the time the test comes and the results come, what could you do with this patient? So they were kept in a COVID emergency unit, but we are all breathing the same air and the patient coughs or there is an aerosol generated, then this will cause a prolonged exposure time. Nurses here were having frequent donning and doffing, which is a huge waste of resources and a lot of waste of time. So this is why I said that resources were not a problem. If they had frequent donning and doffing, they were lucky here to have had adequate PPE. There was frequent aerosol generating procedures, which definitely meant that there was a lot of intubations that were happening, or there were CPRs that were required. So definitely this is what caused aerosol generating procedures. Proning, because you know that COVID-19 causes ARDS kind of symptoms, and frequent proning can actually, who takes the brunt of all the weight of this patient? We might have 6 people, but proning even 3 patients in 6 hours will kill us, because it is a very heavy physical labor. So it is a big challenge if all patients have to be proned, and escorting patients to other hospitals. So if they didn't have beds, or their patients were a little better, and to help accommodate other patients, they were moving patients from our hospital to other hospitals. Who will go? The nurse has to go in the ambulance. So these were challenges that really were faced by nurses in our hospital. Next slide, please. This might be some might be a little different. Yeah, so staffing issues, they had staff segregation. So see, you are running a unit with 146 intensive care nurses, and then you have to divide them into 70 and 70. You have to change their groups, and we know how difficult change is. We all say that change should be accepted, but if one staff nurse has to be moved from one group to another group, they will ask why, how, and they will be unhappy. So they required staff segregation, required shift dynamics to change, because I'm used to working with a particular group of people and suddenly I have to work with different group of people. This actually makes it uncomfortable for staff nurses. I already told you about redeployment from other units. Nurses came from operation theater. Now this is the same thing that happened even in UK. Operation theater or any other outpatient departments, these were places where there were not too many patients then. But how useful and how well can we use these nurses when we are ourselves? If I am a staff nurse in the critical care unit, I know how to work in critical care unit. And if I have new people, I cannot, how to use them, I have to train them. Do I have the time to train them? And if I don't train them, I cannot manage alone. So you are doing your work as well as trying to take care of other nurses and making sure that they take care of patients. These can be severe staffing issues. It could be real burden on critical care nurses, especially. Then rotations and screening and accommodation, because initially we were doing those who became COVID positive among the staff nurses, you have to screen them again by the time they come back. So rules kept changing. Interestingly, then after a quarantine, it was becoming too much that people, the WHO declared that there is no need for screening nurses after the quarantine period. These are all things that happen. But in between, when it had to be done, it was very big challenge. Rotation, screening, providing accommodation for all these people, because accommodation is always a challenge everywhere, because we do not have so much of free accommodation available to accommodate nurses who don't want to go back to their families or to their usual place. The other challenges with equipments were taking inventory for personal protective equipments. We had to buy new machines, we had to buy new monitors, new ventilators. So all this then needed to be coded, to be put into inventory. Then you need to have a checklist, you need to maintain this checklist. So all this becomes administrative responsibilities. So these were the issues that were reported, other than the regular things like making the physical space to accommodate COVID patients. Then infection control training for donning, doffing, use of equipments, supervising donning and doffing, supervising removal of waste. So these are problems that everybody probably had, so I'm not talking about it. Next slide, please. Next slide, please. So this was about Oman. The next one I'm going to talk to you about is UK. I have friends in UK as well, and that's why it's written as anecdotes. This came from somebody in UK whom I know very well, who was working in a COVID unit, suffered from COVID, almost died. This nurse who told me this almost died. He said, I felt like it was my last day, because he had severe breathing difficulties. And just because of his own resilience and maybe grace and prayers that we all did at that point of time, he survived to tell me what was the problems that uh, he faced in their unit. So there were severe communication challenges, because with different guidelines to be followed in 124 hours. That means WHO said something in the morning, then they would say something in the afternoon or evening or the next day or every few days. We were all facing different guidelines, and before we implemented one, there was another one. And if we didn't know about it, then we were not doing the correct thing. So there were huge communication challenges that were reported. UK itself, as you know, UK and US were all, we in India started being careful much earlier than UK and US, because they thought this is only going to affect third world countries. They did not take it seriously. So that was a big problem they had, that communication. That problem also the nurses had to face. There was delay in getting test results. It took sometimes up to 3 days, and it resulted in spread of the infection. There's a big challenge in supporting mental health issues of patients. Like we said, that patients were dying or they were not able to see their family members. They were seeing this robotic dressed nurses and doctors or whoever, and they did not even know who was a doctor or a nurse for that matter. So there were big mental health issues that patients had. Strict isolation was difficult in the beginning due to shortage of staff, due to lack of awareness. Some of this is the same that I spoke before. Nurses were also used for vaccination drives to cover maximum people in less time. So probably you did work till late evening or late night, so that vaccination could reduce admissions and critical care conditions for people as well as for nurses. In UK, they had this unique problem of supporting Black ethnic minority staff, and this is actually there on YouTube as well, that they found that people of ethnic minority like Indians and the Black died more than the white people. Now, this talks for, I shouldn't use the word, I mean, I wouldn't know. I would say this is discrimination or allotments that were done that caused this kind of a problem. And there was a big discussion, even in their parliament, about who was being exposed and who died maximum caring for COVID patients. There was lack of preparation, lack of education, and a big challenge in educating staff about donning and doffing. So these were the issues that I did not put them into categories, because then it will take a longer time. And basically, all these issues are the same that we would have seen in other places, and they're no different. What I want to tell you here is, if I took information from the paper or I asked real nurses, whatever was said seems very, very much the same. The other country that I want to cover is Canada. Next slide, please. From Canada, I got this anecdotes from a friend in Canada, and they had the same thing, differing WHO guidelines, which is repeated and repeated again and again. These people spoke about backlog and neglect of patients with non-COVID health issues. I think we all had this, like patients who routinely required appendectomy or a bypass surgery or a hip replacement or a knee replacement. These patients were all neglected, and probably now we are facing this backlog. Huge number of patients who have to be treated. Many would have died because they were not treated in time, but it was COVID, and these other patients who have routine health problems were neglected. Nurses are so much used to providing individual care in Canada, and family-centered care in Canada. They look at family as a unit, and they are used to talking to families not alone to the patients. But in COVID, all of us saw that we were only looking at patients. We didn't even know whether they had families. There were many families that even dumped patients and ran away because they were afraid they would get COVID. So these were all issues. Patient flow, there was crowds and chaos. Though there were no routine patients, there was a lot of COVID patients, and there's increased number of patient flow. So there was no system, because it is COVID and people could go to any hospital. So this caused a lot of unsystematic processing of patients. Staffing issues were there in Canada as well, and the same personal risk and risk to families. This was something that was told, went on everywhere. Now, before I conclude, I was also asked to talk about the role of nursing professionals or nursing practitioners. And I just put a few points down, because the role of nurses are not limited to patient care. There are huge public health roles that this COVID showed nurses did, and that is why WHO had extra recognition for nurses. So according to research published in the Annals of Global Health, the nurses played an important role in PPE management, minimizing the need for PPE. They really saved and scringed then. And this is how the nurses landed up doing a lot of work, because there was no PPE to waste. So they kept doing everybody's job. They also managed to educate staff. They were coordinating the PPE supply chain and were also reducing PPE use. So this is one major thing about managing resources. Who managed the resources? Nurses managed the resources, whatever was supplied to them. The nurses also were building trust and educating people about the facts of coronavirus. Facebook was full of examples on how nurses were telling people, to stay at home, to go for vaccination, telling them about how corona is spread and not to hug and shake hands and to follow hand hygiene. These were all things that were done by nurses, and this cannot be overstated. Nurses did a lot of public awareness initiatives, and they guided people to health service, supporting evidence-based patient management. They followed a lot of infection control reduction initiatives. So this was done by nurses. So this was all nursing roles done by nurse professionals or nurse practitioners. Nurses participated very, very much in many Western countries, though it is very clearly reported. WHO said that nurses must be involved in all policy making, but what actually happened in hospitals is They never included nurses in the policy making. They never called nurses for the meeting. They had this good excuse that nurses were busy, and sometimes the physicians made all the decision. And the sad thing is, all this policy making was supposed to be done along with the nurses, but nurses became the followers of policies. And this was very difficult for them, because when nurses are not involved in policy making and are asked to follow, they don't understand exactly where it comes from. It creates anger, it makes people upset. So in the realm of policy making, in Western countries there was a lot of participation, but in many other countries there was a lot of issues, because we were asked to follow policies which we did not as nurses make. However, they have been advocating for patients and their families. Next slide, please. uh, so finally, a global pandemic sorry, there was anything more? Yes, there was one more. Please go to the previous slide. One more, the previous slide. Yes. So the nurses were working in non-profit and research institutions, where their they use expertise to conduct research. They played a role in many decentralized community health programs. So I wanted to talk about population level services. This is one of the times when nurses change their role. So, for example, if they found a group of people or a community where there was no vaccination, then the nurses focused on vaccination. A community where people were not aware or not wearing masks, then that community was targeted and not individuals. So population level services were provided by nurses, and a lot of community health programs were also initiated by nurses. There was a lot of training for next generation nurses. So there were a lot of senior nurses and educators who got into training the next generation nurses. So I have been reviewing studies where nurse educators were responsible for training, like, quick, like you have nurses from non-critical areas. In less than 24 hours, education program was put in place, and nurses were taught about how to deal with endotracheal tube, what is a ventilator, how to do suction, how to do CPR. So a quick 8-hour, 10-hour, 12-hour lecture come demonstration using simulation, using lab training, was given to nurses who were not from critical care areas, so that they could be helpful to nurses within critical care areas. So this is how education actually contributed to COVID-19. Then nurses were used for effectively supplying and making use of sanitation materials, personal equipments. This is something repeated. Screening information, checking whether guidelines were being followed, triage protocols and new protocols for triage due to COVID were all being managed by nurses. So there was a lot of things that nurses did. I don't want to say it is only bedside. What's my message here is, it was a huge role. And I'm glad that we were recognized, and we need to use this momentum to take the limelight and continue to push for reforms, and not now say, okay, COVID is over, so I will relax and we will all go back to our old tortoise shells and never be seen again until another pandemic. This shouldn't be happening. So I hope we take advantage of the limelight that we received to be able to go maximum and take advantage of the situation to improve patient care and nurses professional services. Last but not the least, next slide. The whole world recognized that a global pandemic like COVID-19 required strong staff engagement, nursing staff engagement. For what? In clinical management, in awareness and knowledge exchange, as well as to keep this public safe. So we have, as nurses, a big, huge role, and we need to be seen in these areas, just not in hospitals, in small settings, but actually as change leaders and change management experts, so that we are able to deal with, I hope not another pandemic, but at least improve the healthcare services to face any other global crisis. Thank you very much. I think I just managed to finish in time. My references are there on the next slide. Next slide, please. These are the 3 references, and the other references of the articles, I had put it on the side of the slide itself. Next slide, please. Thank you very much. Any questions? I would like to ask if Prasanna is still around, if he has listened to me about what was the difference between dealing with things in India and all that I said about abroad. Thank you so much. And if anybody has any questions, I'll try to answer them.
Time for the discussion. Please raise the questions.
Any questions? No questions. Thank you,
There will
ma'am.
never be questions, but Prasanna is there?
No questions, ma'am. Shita.
Yeah, Prasanna is there? Prasanna Kumara?
Thank you, ma'am, for your wonderful session. From your experience, we could understand the contribution, role, challenges of nurse practitioner during COVID pandemic. Thank you, ma'am. Thank you so much. Now I call upon Mr. Sushma to propose vote of thanks.
Good evening to all of you. On behalf of organizing team, it's my privilege to propose vote of thanks on this occasion. My special thanks and gratitude to all distinguished speakers for spending your precious time on this day. I would like to thank our management for supporting us in organizing this webinar. I thank our principal, Dr. Larissa Martha Sam, Vice Principal, Dr. Teresa Lida Mendonça, and organizing chairperson, Dr. Diana Lobo, HODs, teaching and non-teaching faculties of Lakshmi Memorial College of Nursing. I also extend gratitude to all the delegates for your patience listening. I also thank the technical team for their support. Once again, I thank each one of you.